Good day everyone, this is Mary Rose Garcia, a second-year nursing student from Section WIEDENBACH. So for today's video, I'm going to perform on how to administer nasogastric tube feeding. For the definition, it is an installation of a specially prepared nutrients into a stomach through a nasogastric tube. First, you have to assess the need for enteral tube feeding and impaired swallowing, decreased level of consciousness, head and neck surgery, facial trauma surgeries of upper alimentary canal. Identifying the clients who need tube feedings before they become nutritionally depleted. To auscultate for bowel sounds before feeding. Absent bowel sounds may indicate decreased ability of gastrointestinal tract to digest or absorb nutrients. After that, we have to obtain baseline weight and laboratory values, assess client for volume fluid deficit or excess, and electrolyte and metabolic abnormalities such as hyperglycemia. So, enteral feeding is to restore the client's nutritional status, provide objective data to measure the effectiveness of feeding. Verify the physician's order for formula, rate, route, and frequency, laboratory data, and bedside assessments such as finger stick, blood glucose measurements are also ordered by the physician. Since tube feedings, laboratory tests, and bedside tests should be ordered by the physician. For the objectives, it is to provide alternate means of ingesting nutrients for patients with functional gastrointestinal tracts. Next is to intervene in pre-existing or impending nutritional depletion from debilitation. Provide aggressive management for certain disease conditions such as anorexia. Provide means of nutrition if there is an inability to swallow or an existing obstruction in the upper alimentary canal. Also, to provide nutrients for the patients who are comatose or semi-conscious state. To provide increased nutrition requirements above oral consumption. To provide nutrients for post-operative patients with bowel sound present. And also to maintain fluid and electrolyte balance. For the equipments, we need to have disposable feeding bag or tubing or ready-to-hang system. 2 to 50 ml syringe, stethoscope, our pH indicator tip, prescribed enteral feeding formula, our gloves, our equipments to obtain glucose by finger stick, our kidney basin, our water to follow feeding in a measuring or calibrated glass, and also our measuring container from which to pour the feeding if the syringe method is used. And lastly is our tissue. For general considerations, first you have to verify tube placement before the feeding and establish patency of the tube. Next, we have to ensure that the client is sitting upright on a chair or in a bed and to infuse the feeding slowly. Next is to report any difficulty in infusing the feeding or any discomfort voiced by the client. Also, auscultation is no longer considered as a reliable method for verification of the tube placement because air in tube are inadvertently placed in lungs. Larynx and esophagus can transmit sound similar to the air entering our stomach. For obtaining GI fluid for pH measurement, large and small bore feeding tubes, and bolus and continuing feeding. So for timing of pH testing, we have to wait at least 1 hour after oral or tube administered medications. Wait as long as possible after last feeding, and this is important because formula elevates the pH or gastric contents. For intermittent feeding, test pH immediately prior to administration of new feeding, usually at least 3 hours after previous feeding. And for continuous feedings, plan pH testing at times when feeding may be withheld, such as for chest physical therapy, transport of the division for test, or avoidance of medication interaction. Flash tube with for about 30 ml of air. And after that, we have to aspirate GI contents. If unable to aspirate GI contents during the first attempt, reposition client to allow tip of tube to rest in the pool of GI tract, flush tube with an additional 30 ml of air, and attempt to aspirate. For the procedure, first we have to explain the procedure to the client, since explanation helps allay anxiety and also encourage the patient's cooperation, and also to give what the patient what they expect. So for today, I'm going to perform nasogastric tube feeding, and I'm going to administer all the nutrients ordered by the doctor, and also your medicine in a solution form. And all you have to do is to follow the instructions, okay? Next, we have to perform hand hygiene and wear gloves, since hand hygiene deters the spread of microorganisms. So after that, we have to prepare feeding tube container to administer formula and have this in a room temperature. Since cold formula may cause gastric cramping and discomfort because liquid is not warmed by the mouth and the esophagus. You have to connect tubing as needed or prepare ready to hang container. And the tubing must be free from contamination to prevent bacterial growth. So we have to fold this to prevent the air from entering the stomach. After that, we have to shake formula container well and fill container and tubing with formula. Filling tubing with formula prevents excess air from entering GI tract. Next, we have to place our clients in a high shoulders position or at the head of the bed for about 30 degrees. So this is to prevent aspiration. Next, we have to determine tube placement. Aspirate gastric tubes to check for gastric residua, since the presence of gastric secretions indicates that the distal end of the tube is in the stomach. Residual volume indicates of gastric emptying is delayed. So delayed gastric emptying may be reflected by 150 ml or more remaining in the client's stomach. So return aspirate contents to stomach unless the volume exceeds to 150. Next, we have to measure pH of aspirated GI contents, since it is usually equal to or less than 4, and it is only infrequently greater than 6. In contrast, intestinal aspirates usually have a pH equal to or greater than 7. Observe for the aspirate's appearance. So, gastric fluid is usually cloudy and grassy green or tan, or off-white in color. In contrast, intestinal fluid is usually deep golden yellow and is clearer than gastric contents. Next, we have to consider the results from pH testing and the aspirate's appearance together. An aspirate with a low pH and a typical gastric fluid color indicates a high probability of gastric placement. In contrast, a golden-colored aspirate with a high pH indicates a high probability of intestinal placement. After that, we have to initiate feeding. Initiate feeding, bolus or intermittent feeding. Pinch proximal end of the feeding tube. Remove plunger from syringe and attach bar of syringe to the end of the tube. This prevents air from entering client's stomach. So after that, we have to fill syringe with measured amount of formula. And then, release tubing and hold syringe high enough to allow it to empty gradually by gravity. And then, we have to refill and repeat until the prescribed amount has been administered. If feeding bag is used, hang feeding bag on an IV pole, fill bag with prescribed amount of formula, and allow bag to empty gradually over for at least 30 minutes. So, gradual emptying of tube feeding by gravity from syringe or feeding bags reduces risk of abdominal discomfort, vomiting, or diarrhea induced by bolus or too rapid infusion of tube feeding. For continuous drip method, we have to hang feeding bag and tubing on IV pole. So, continuous feeding method is designed to deliver prescribed hourly rate of feeding, and this method reduces risk of abdominal discomfort. Clients who receive continuous drip feeding should have residuals checked every 4 hours and tube placement verified. So, connect distal end of tubing to the proximal end of the feeding tube, and then connect tubing through infusion pump and set rate. After that, we have to advance tube feeding gradually. So, we have, don't wait that don't allow that the feeding tube will be empty, but pour the solution on it. It should be advanced gradually to prevent diarrhea and gastric intolerance to formula. So when tube feedings are not administered, cup or clamp the proximal end of the feeding tube to prevent air from entering the stomach between feedings. So for example, this is our clamp. Proximal end. So after that, we have to administer water via feeding tube as ordered with diluted formula. Unclamp the tube and then administer water. This provides client with source of water to help maintain body fluid and electrolyte balance. So after that, we have to take off the bag or the tube feeding container and then put the cup or the cup. And then we have to rinse the bag and tubing with warm water whenever feedings are interrupted. So rinsing bag and tubing with warm water clears old tube feedings and reduces bacterial growth. And measure amount of aspirate every 4 hours to evaluate tolerance of tube feeding. So we have to monitor intake and output every 24 hours since it is an indication for fluid balance or fluid volume deficit or excess. So after that, we have to weigh client daily until maximum administration rate is reached and maintained for 24 hours. Then weight client 3 times per week. So weight gain is indicator of improved nutritional status. However, sudden gain of more than 2 pounds in 24 hours usually indicates fluid retention. And after that, we have to observe the return of normal laboratory values since it indicates an improved nutritional status. After that, we have to remove gloves and wash our hands since hand hygiene deters the spread of microorganisms. For the evaluation, patient tolerates feeding well and the weight of the patient is maintained or increased. A proper residual is obtained from aspiration of stomach contents. Patient complies with feeding procedure. The intake and output balance is maintained and the nasogastric tube functions efficiently and remains patent. For documentation, record the amount and type of feeding, the client's response to tube feeding, the patency of tube and any side effects, and also report the client's tolerance and adverse effects. So that would be the coverage of our nasogastric tube feeding. Again, this is Rose Garcia, a second-year nursing student from Section 1 in Batch. Thank you and God bless us all.